Okay, hello, good evening. Today going to continue our recall revision for Fawzia Sheet 2, the second part and second half of our session. Okay, start from question 91 with Dr. Mu'tasim. Okay, Dr. Mu'tasim, you can start.
Which of the following statements is true with relation to cardiac muscle? Contraction does not involve release of calcium by the sarcoplasmic reticulum. Contraction is triggered by influx of calcium ion through the sarcolemma. Excitation is passed from one cardiac cell to another through desmosomes. Hypertrophy is brought about by division of existing cardiac cells. There is capacity for regeneration. The answer is B. Contraction is triggered by influx of calcium ion through the sarcolemma.
Exactly, this is a repeated question since yesterday, one of the physiology question. Yani, we always say some physiology question you find in the exam in new, and sometimes you don't find an MRCS or fast test. It's used to have about up to 20 questions or up to 15, 15 to 20, 15 question maximum, 10 to 15 questions new in paper one, mostly will be in physiology and pathology. And contraction is triggered by influx of calcium through the sacrolemma. Okay, next question.
A 39-year-old man presents with tearing left-sided line to groin pain. Investigation reveals a radiodense opacity confirmed to be in the ureter on intravenous urography. What is the most likely composition of this man's ureteric stone? Ammonium, magnesium, phosphate stone, calcium oxalate, cholesterol, cysteine, urate. It is calcium oxalate stone because it is radio opaque.
Okay, so calcium oxalate.
Calcium oxalate.
Most common stone, renal stone. Calcium oxalate. Okay. If he asks you about a hereditary problem in the patient,
it will be cysteine stone.
Cysteine stone. If the patient has a debilitating disease, taking chemotherapy, losing weight, or cachectic patient, your malignancy and something like this, it will be
urate stone, but it will be radiolucent.
Urate stone. So this will have be some sort of inherited, and this will have some debilitating disease like chemotherapy, cancer, and so on. Okay. So answer here will be calcium oxalate stone. Next question.
A 25-year-old man is playing football when he complains of posterior thigh pain while sprinting with a ball. On examination, he has tenderness in the lower lateral posterior thigh. He is unable to fully extend the knee due to pain. What is most likely injury? Biceps femoris tear, gracilis tear, gastrocnemius tear, semimembranosus tear, semitendinosus tear. A complaint of posterior thigh pain while sprinting, tenderness in the lower lateral. Because of its lateral, it will be biceps, lateral biceps femoris tear.
Okay, so it will be biceps femoris tear. Okay, because here is the biceps femoris. The other side is semitendinosus, semimembranosus will be on the other side. Will be medial. Okay. Next question.
20. 23-year-old man is assaulted and sustains a stab injury to the left groin. The wound is cleaned and a simple dressing applied. 6 months later, the patient returns with a pulsatile swelling in the site of the injury. The most probable lesion present is abscess, false aneurysm of the femoral artery, lymphocele, mycotic aneurysm of the femoral artery, saphenous varix. The one with a pulsatile swelling, I think it will be false aneurysm of the femoral artery.
False aneurysm of the femoral. I think this repeated question from the first sheet. Okay, there is no signs of stab injury, left groin, wound is clean and simple dressing applied. 6 months later, a pulsatile, and this. There is no signs of infection. There is no signs of varicosity on the lower limb, and so this will be mostly the most common here will be a false aneurysm of the femoral artery. Okay, next question.
12-year-old girl has a diastolic murmur. It's maximally audible in the second left intercostal space. Which structure is most likely cause this pathology? Aortic valve, ductus arteriosus, mitral valve, pulmonary valve, tricuspid valve. As it is here in the second left intercostal space, so it is pulmonary valve. It's pulmonary valve. Number D. Yeah. Option D.
As we said, second right will be aortic area. Second left will be pulmonary. Tricuspid will be left parasternal fourth intercostal space, and the mitral will be at the left
pulmonary
intercostal space, mid
tricuspid mitral.
Mid axillary. Very important to know all of this, by the way. Very important. Aortic, pulmonary, tricuspid, and mitral valve. Next question.
A 25-year-old man is admitted having been stabbed in the interior chest. On examination, he is alert and coherent. He has congested neck veins. His pulse is 140 beats per minute, and his blood pressure is 90/60 millimeter mercury. He has normal breath sound. What is most likely cause of his cardiac arrest 15 minutes later? Cardiac tamponade, congestive heart failure, hypovolemia, tension, pneumothorax, ventricular arrhythmia. Due to congested neck veins and hypotension, I think it is cardiac tamponade. This is big triad. Congested neck vein, hypotension, and the muffled heart sound. He didn't mention muffled heart sound. This is cardiac tamponade.
Okay. What will be the difference if it is tension pneumothorax?
Will not be congested. There is no congested neck veins with tension pneumothorax.
Normal breath sounds also. Normal breath sounds will be cardiac.
Absent breath sounds.
Absent breath sounds, especially absent breath sounds, because some pictures with tension. By the way, some pictures of tension pneumothorax can have congested neck veins because of the heart can't. It is there is tension and there is deviation of the heart to the other side with kinking of the blood vessels. You can sometimes have congested neck veins. Sometimes.
Okay.
But he have to exclude muffled breath sounds, and this needs to tell you that breath sounds equal here means the problem is in the heart. This is cardiac tamponade, peaks triad, hypotension, muffled breath sound, and jugular venous distension. Next question.
A 20-year-old woman presents acutely with abdominal pain. Imaging reveals a right ovarian cystic lesion which is excised. Histological examination shows a cyst lined by keratinizing stratified squamous epithelium. Area of fat, muscle, thyroid, and the neural tissues are seen in the wall. What is the appropriate pathological designation for this lesion? Cystadenoma, dysgerminoma, mesencymoma, squamous cell carcinoma, teratoma. Lesion containing epithelium, muscle, fat, thyroid. I think it is mesencymoma.
Repeated question. This repeated question. You have a found revealed a right ovarian cyst. What is the most common in young age ovarian cyst? And you open and you find fat, muscle, thyroid, teeth, keratinized epithelium. You find some hair sometimes.
Teratoma?
It's teratoma. If you did see teratoma in once in your life, you will never forget it. I opened one teratoma one time. I found hair and teeth and skin and some heterogeneous tissue. You will never forget it. Okay, so this is teratoma. Next question.
A 21-year-old map comes into the emergency department with a severe headache and neck stiffness of recent onset. You suspect acute meningitis and decide immediately to treat with antibiotic and perform a lumbar puncture. After your third attempt to obtain for cerebrospinal fluid, you notice that the fluid obtained is stained red. However, during the collection of cerebrospinal fluid into 3 containers, it is noted that the final bottle is now cleared of any blood. Which anatomical structure is the most likely to be responsible for this bleeding? Anterior spinal artery, epidural artery, subarachnoid vein, veins within the erector spinae muscle, vertebral venous plexus. Vertebral venous plexus.
The most common. Exactly. This is the most common blood come during spinal needle. Okay, when you go for a spinal needle for anesthesia, for CSF collection, you have four group of plexus around the vertebral column. 2 external, anterior and posterior, and 2 internal, posterior and anterior. Okay, inside here is the anterior internal venous plexus, posterior internal venous plexus, anterior posterior and anterior external and posterior external venous plexus. The most common one of these, extradural, it will have bleeding during spinal needle or during CSF collection. Okay, next question.
A 25-year-old woman presented in the surgical clinic with a 3-month history of diarrhea. On examination, she is found to have a smooth 2-centimeter swelling in the front of her neck. Her sister has a similar swelling which was operated on 2 years ago. The swelling moves on swallowing and the patient is clinically euthyroid. Fine needle aspiration cytology of the swelling shows amyloid stroma and the serum calcitonin levels are elevated. Which of the following is most likely diagnosing? Anaplastic thyroid carcinoma, follicular thyroid carcinoma, medullary thyroid carcinoma, metastatic thyroid carcinoma, papillary thyroid carcinoma. It's medullary thyroid carcinoma.
Okay, why medullary?
There is a family history.
Yes.
Her sister has similar swelling, and the patient is calcitonin levels are elevated.
Amyloid stroma. and so on. Okay, young age. As we said before, this is a repeated question, but I repeat again the explanation. When he want to ask you about, we have 3 common cancer you will be asked in the exam. One of them, this scenario, the medullary thyroid cancer, he will give you a family history, because mainly he will ask you about men syndrome, men 2, okay, with family history, and the patient has swelling in the neck, because mainly medullary mainly spread by lymphatic, as we know that medullary mainly by lymphatics, medullary mainly lymphatic, end by Y, lymphatic, papillary lymphatic, papillary lymphatic, follicular blood. Okay, follicular end by R will be red blood, papillary and medullary will be mainly by lymphatic. So when he asks you, when he asks you about medullary or papillary, mostly the patient will be represented by a swelling or a mass in the neck, which is a lymph node, which is spread early from the disease. Okay, so medullary, it will be part of men syndrome. He will tell you the patient has a family history or a swelling in the neck, maybe associated with swelling in the midline of the neck or not. The patient has a family history, her sister, her mother, or something like this. She have high calcitonin, maybe the patient associated with hypertension, maybe the patient associated with hypertension due to
من pheochromocytoma.
Pheochromocytoma, or the patient is associated with high calcium level due to
high calcium level due to parathyroid adenoma.
Parathyroid. So men syndrome, it will be medullary, and it will be have parathyroid hormone, it will be pheochromocytoma. Okay, so any picture of this can give you high calcitonin, can give you the patient has high calcium level. Here will be high calcitonin, here will be high calcium level, or the patient is hypertensive, or a high phenyl mandelic acid in urine. Okay, any picture of this, you want to target your thinking about medullary thyroid cancer. Okay, if he want to ask you about the papillary, he will tell you patient represented with mass in the neck mass by histopathology, thyroid tissue. This is the most common. It will be mostly papillary thyroid mass. If you want you to ask about the follicular, he will tell you the patient presented mass in thyroid plus pulsating and the patient will have pulsating skull or bony mass, because mainly follicular will spread by red blood. Then last one is anaplastic. Will tell you the patient is about 70 years, something like this, and the patient has a neck mass attached to skin and muscles and surrounding tissue. So the mass infiltrating the neck muscle, this will be anaplastic. And the patient will be 70 years, will be middle-aged patient. So this is all the scenarios you will face. You will never find metastatic thyroid tissue here. Nothing. This not came before. Okay.
Okay.
Clear? Yeah. Next question.
A 74-year-old man with known prostatic hyperplasia presents to the emergency department with acute urinary obstruction. 30 minutes after urinary castorization, he collapses with blood pressure of 74/34 millimeter mercury, a heart rate of 128 beats per minute. What is most likely diagnosis? Cardiac failure, hemorrhagic shock, latex allergy, septic shock, vasovagal syncope. Hypotension, tachycardia. I think it is latex allergy, anaphylaxis. Okay, I think it will not be cardiac failure, not be hemorrhagic shock, not septic shock. So,
very common, by the way. Collapse.
Latex
Patient
allergy.
Yes, exactly. It's very common. Very common latex allergy happen with patient when during castorization, or sometimes a patient wearing gloves or at touch with gloves, latex gloves. The patient will have a latex allergy. Okay, very common, by the way.
Okay.
One of the very common examples in the exam. Sometimes part B, you have to ask in the castorization.
As a urologist, Dr. Rami, it's only with the back quality casters. And I didn't see too much with the good quality casters.
That's quite good. لا, but يعني, this is a recorded allergy. يعني recorded allergy. Even in part B, you have a castorization, station. You have before castorization, if you are going to put a Foley caster, to ask the patient, do you have any allergy from latex? Very common allergy and the recorded allergy, by the way. I think Dr. Mu'tasim is also urology, yeah?
Yes. I didn't see at all. I didn't see this reaction at all.
Yes.
Well, never me also. Okay, next question.
A 70-year-old man has a basal cell carcinoma resected from his left temple. What is the most important prognostic indicator? Clinical pathological type, completeness of excision, intensity of the lymphocytic infiltration, lymphovascular space invasion, mitotic index, and the tumor island. It is basal cell carcinoma. The most important prognostic indicator is clinical pathological type, completeness of excision, intensity of lymphocytic infiltration. I don't know.
Completeness of excision.
Okay.
Basal cell carcinoma is mostly a local or tumor with local invasion. Yani it is just one of the tumors that not spread, and we rarely found it spreading tumor. It's just tumor. We can say tumor in situ. But the most important that you have to remove the tumor completely. You have to have a safety margin clear from it. It is well determined in front of you. And I did maybe 2 cases before in the face with a rhomboid flap. Really amazing. You have to go it through and full thickness of the skin and subcutaneous tissue. So complete resection of the tumor. It will be the most best prognostic factor is that you completely excise the tumor. There is no lymphocytic infiltrate, lymphovascular space invasion. I think the same. You're taking the same also. Mitotic index, no. Clinical pathological type will not affect as you completely removed it. So it is the best Prognostic factor is completeness of removing the tumor. Okay.
Okay.
Next question.
A 68-year-old man has undergone emergency surgery to repair a leaking aortic abdominal aneurysm. He underwent a transfusion with 6 units of packed red cells. Blood tests were performed 2 hours post-operatively. Hemoglobin 10.1 gram per deciliter, white blood cells 12.3, platelets 40 by 109 per liter, which is low. Activated partial thromboplastin time 36 seconds, INR 2.2, fibrinogen 1.5 gram per deciliter, fibrin degradation products 25 milligram. What will these results be consistent with? DIC, disseminated intravascular coagulation, inactivation of antithrombin 3, increased level of vitamin K, plasminogen inactivation, protein C deficiency. It is disseminated intravascular coagulation due to thrombocytopenia with increased fibrin degradation products.
This is acute coagulopathy caused by infusion of large amount of RBCs or blood. The patient went through a massive transfusion, low platelet, and the consumption of the coagulation factors and the clotting factors, high INR, high fibrinogen, and high fibrinogen degrading products, and so on. All this gives a picture of DIC. Next question. Wait. Who's ready to continue after Dr. Mu'tasim?
I'm ready.
Dr. Daf. Okay. Welcome, Dr. Daf.
Okay. I continue or?
Oh, continue, yes.
Yeah, okay. 46 years old woman.
Thank you, Dr. Mu'tasim.
Thank you, Dr. Rami. Welcome, Dr. Daf.
Welcome. Thank you. 46 years old woman is seen in the pre-admission clinic. She has a myocardial infarction 2 years ago. On examination, she is on atrial fibrillation, and recently echocardiogram show that she had dilated left ventricle. She is on warfarin, and INR international ratio is 6.1. Warfarin inhibit which of the following? Antithrombin, chylocrene, plasminogen, prothrombin, vanulibrant. It's D.
Yes, repeated question. Prothrombin inhibit. Warfarin inhibit prothrombin. Warfarin inhibit prothrombin. Okay.
Okay.
Next question.
A 29 years old pregnant woman is having uncontrolled labor pain. She has an epidural for the pain relief. Which of the following is true? An epidural puncture should only be done below the L1 level to avoid damage to the spinal cord. Epidural puncture should be performed below L4 level to avoid the spinal cord. The spinal epidural space, also known as extradural space, contain numerous nerve fiber, nerve root, and the venous plexus. The ligamentum flaccidum is rarely prized during the low epidural procedure. The supraspinatus and infraspinatus ligament are rarely prized during the procedure. It's C.
Exactly. Epidural or extradural space contains venous plexus, internal anterior and posterior internal venous plexus, plus the emerging nerve roots. This space, exactly. This is space around the spinal cord. Okay.
A 25 years old motorcycle presented to the emergency department after being involved in the road traffic accident. He has a close isolation injury to the right leg. Radiographs show a segmental fracture of the tibia and fibula. A transmedullary nail of the tibia is undertaking 6-hour follow operation. He complained of the severe calf pain, which does not respond to the analgesia. Movement of the toes severely increase pain. What is the most likely cause for these? DVT thrombosis, deep infarction, emboli, raised intracompartmental pressure, movement of the unstabilized fibula. So it's D.
It's D. Raised intercompartment syndrome. Okay, so this is a young patient, emergency part being involved in road traffic accident, close isolated injury to the right leg. Radiograph show segmental fracture of tibia and fibula, both bone fracture, intramedullary nailing. By the way, very common in the exam. Intramedullary nailing, okay, of the tibia undertaken, and 6 hours the patient complains of severe calf pain, not responding to analgesic movement, increase the pain. This is a typical picture of raised intracompartment syndrome or intercompartment syndrome. Yani intramedullary nail, you'll find it in two scenarios, by the way. Some other scenario asks the patient after patient has fractured femur and went for intramedullary nailing, and maybe old patient or middle-aged patient, and after operation the patient has chest pain, tachycardia, and hypotension. What will be? Middle-aged patient.
Yeah.
What you expect to have this patient? Middle-aged patient or old-age patient has fractured femur. The patient went to operation. The patient put intramedullary nail in the femur. Post-operative few hours, the patient starts to have chest pain, difficult breathing, tachycardia,
Emboli.
fat embolism. I don't know why they like this scenario. They like patient fracture femur with intramedullary nail, followed by chest pain, difficult breathing, tachycardia, sometimes, and decrease oxygen saturation. Sometimes, if you want to make it easy for you, so this patient will have a fat embolism. Fat embolism. Just remember this scenario in your mind. Next question.
65 years old woman with metastatic breast cancer is admitted to the hospital, confused and acutely unwell. His nausea, vomiting, his vital signs are within the normal limit. What is abnormality in the most likely to contribute to her clinical condition? Hypercalcemia, hyperkalemia, hypocalcemia, hypokalemia, hyponatremia. So it is A, hospitalized.
Okay. Breast cancer, metastatic breast cancer, confused, mostly due to hypercalcemia. Vomiting, vital sign normal. What is the most? Hypercalcemia from metastatic breast cancer. Next question. They like it so much about the common perennial.
During recovery from the varicose vein surgery, 35 years old woman complained of weakness of the dorsiflexion of the ankle. Physical examination revealed absent sensation over the dorsum of the foot. Which of the following nerve is most likely injured? Common peroneal, deep peroneal, saphenous, superficial peroneal, and sural nerve. It is common.
So this patient is common perennial
Yeah.
nerve. Why?
Because it's dorsiflexion and dorsal of the foot. It is okay. L5, L4. Okay.
What is responsible for dorsiflexion of the foot?
L4, L5.
Now, which nerve from the choices?
Superficial.
Dorsiflexion of the foot.
Deep peroneal.
Deep peroneal.
Deep peroneal because it supplies the anterior compartment of the leg.
Okay, what's the responsible for absent sensation at dorsum of the foot?
Superficial peroneal.
Superficial peroneal. So you have in the question both of them. So you'll go for common peroneal. But if he told you the patient have a difficult in eversion of the leg of the foot, eversion will be, by the way, this question comes by many pictures. You have to concentrate and do what I'm doing. Eversion, if it is eversion,
So it is
sometimes gives you
superficial
eversion plus on the other side till he says sensation, dorsum sensation. So this will be superficial. Sometimes tell you patient has dorsiflexion, loss of dorsiflexion plus he loss of sensation over the first web space.
This is deep.
So it will be deep peroneal, deep peroneal. If he mix between any one of these, so you already injured the
common peroneal.
The origin كله. The origin, this includes this one and includes this one. Clear? Take care of this question and you have to answer it by this way. Here is given to you deep peroneal, superficial peroneal, or common peroneal. You have to know that these signs, if he mixes the signs, so you injured the main trunk of the vein. Okay? Okay?
Okay.
Again, the last
Clear?
Dr. Mustafa شكله is on call now. So
yeah. He's always busy, yeah.
Yeah.
Okay.
So the last word when you tell about if dorsiflexion and eversion also, we say the origin common peroneal.
Common peroneal. If he mixes the two signs, common peroneal.
The two
Clear?
sides. The two sides.
يعني if he makes the two signs for each one, we say it's the deep peroneal, dorsiflexion plus first web space. Superficial peroneal, we said eversion and dorsum of the foot. If he get two different from two nerves, so you injured the common peroneal. Clear?
This last exam برضه debate about this question. But
still confused? Still confused? Right.
You know what the question is from, yeah?
Okay, common peroneal. Common peroneal. تمام? Give us superficial, deep. Superficial give eversion, and loss of sensation at dorsum. All the dorsum of the foot. Deep give us dorsiflexion, and loss of sensation only the first web. Okay? So if I have injury in this only superficial, if I have injury on superficial, what I will have?
Only eversion.
I will have loss of eversion and loss of sensation on the dorsum. If I have injury on the deep, I will have loss of dorsiflexion and loss of the first web space. If I have injury of this common peroneal, I lose all of this. Okay? Here, he told you the patient has loss of, sorry. He told you the patient has loss of dorsiflexion. So you injured what? The deep. And then come again and tell you the patient has loss of sensation at dorsum of the foot. So you lost the superficial. So he wants you to tell you he makes the injury was up here. He gave you a sign of injury of the deep and a sign of injury of the superficial.
Exactly like September 2020.
What?
The same question, September 2020.
Okay. Sometimes he tell you the patient has loss of eversion and loss of sensation on the first web space. But he will not tell you this. He will not. He will tell you also the dorsum, because the dorsum will include the first web space. So, but it will be. He will not bring common peroneal in the exam. He will give you superficial. This will be maybe superficial, maybe the common peroneal. So you will not have this answer in the exam.
Foot drop.
Foot drop, loss of dorsiflexion. This equals foot drop. So this is initially deep peroneal. Go for the sensory of only the first web space. So it will be only deep peroneal. If all the dorsum of the foot, it will be the common peroneal. Clear?
Yes, clear.
Yalla. Next question.
78 years old woman. 78 years old man with a chronic obstructive pulmonary disease become confused and write hemocoloction. He is on the 30% oxygen and her blood gas is shown. The PO2 is 8.5, the normal range, or 4.7 to 6, and PO2 6.2, and the normal range 11.9 to 13.3. What is the most likely suffering? So it is the hypercapnia. What is the most likely suffering? Severe asthmatic attack.
What do you expect from the ABG?
It is decrease hypoventilate and decrease response to the oxygen.
This patient has a high CO2 and low oxygen.
On failure.
This patient on failure. Respiratory failure. Which one?
First one. Second one. Type 2.
Type 2 high. Don't be confused. Equals, sometimes give you pH and so on, equals respiratory acidosis. Equals respiratory acidosis. Okay, just always remember that. Type 1 is only one parameter defect. Type 2 is two parameter defect. Okay. Type 1, only hypoxia. Only hypoxia. Type 2, hypoxia plus hypercapnia.
Type 2 respiratory acidosis.
Type 1 and type 2 respiratory failure, whatever. Type 2 is the respiratory acidosis. Type 2 respiratory acidosis. Okay. Next question.
A 19 years old man fall down from flight on the stair. On presentation to the emergency department, he is a Glasgow Coma scale 14 with no focal neurological sign. An hour later, vomiting, he is Glasgow Coma scale deteriorated to 10. He developed a fixed and dilated left pupil. Which of the following account for the papillary sign? Compression of the oculomotor nerve, parasympathetic fiber, compression of the sympathetic fiber of the left iris, compression of the efferent fiber of the left optic, compression of the Edinger wasteful nucleus, compression of the optic chiasma. So it is compression of the oculomotor nerve.
Compression of the oculomotor nerve. Why?
Okay. No, firstly, because it is the same side. It's not mentioned to the left side, but it is supply the eye.
Mm-hmm.
Yeah, this is first one. And
Okay, if here compression, you have two choices: compression of the oculomotor nerve, parasympathetic fibers, and you have another choice: compression of the oculomotor nerve, sympathetic fibers, or a compression of the sympathetic fibers. Which one will be more accurate? And what is the difference between sympathetic and parasympathetic here?
Parasympathetic because vasodilated, or not vasodilated.
What sympathetic? What sympathetic do in the pupil, and what parasympathetic do in the pupil?
Yes, one dilated, one constricts pupil.
Which one dilate and which one constrict?
Sympathetic constrict.
Sympathetic?
Sympathetic dilated.
Dilate. Parasympathetic constrict. Okay. Patient who have dilated pupil, that means you have abolished the parasympathetic effect. Abolish the sympathetic effect. Compression of the parasympathetic effect. Okay, sometimes you can't find oculomotor, no fine, but you have here, we want to differentiate between sympathetic and parasympathetic. Okay. Can we look to this nice photo? This nice photo tell you this is the normal eye. When you go toward the parasympathetic effect, as the parasympathetic effect predominates, it makes constricted pupil. As you go towards the sympathetic effect, the eye dilated. This is parasympathetic way, and this is the pupil constriction, mainly parasympathetic. Pupil dilatation, mainly sympathetic. Clear?
Yes, it's now clear.
Clear now?
Yeah.
Okay, that's why, and when he tell you why in head trauma and then happen, and then there is dilated first for our the eye will be there is extradural hematoma or intracranial hematoma. First, you will find the eye irritated and constricted, followed by dilated fixed pupil. Dilated fixed pupil. What is the cause of dilated fixed pupil? Predominant sympathetic effect of the eye. Predominant sympathetic effect of the eye, and abolishing the parasympathetic effect. Both of them working together to make the eye in the middle. If one of them overact, it will cause its cause. In dilated fixed pupil, this is, we say, predominance of the sympathetic effect overacting over or abolishing the parasympathetic effect. Clear?
For me, not. It's because it started confused.
Not clear. Started not confused. The ciliary muscle supplied by sympathetic constricted ciliary muscle. Okay, supplied by
trigeminal parasympathetic. Yeah.
Sorry. Try to do something.
Okay, it's better now.
Yeah, sorry. Yeah, okay. Yeah, please. ماشي. Here is the eye. Here is the eye. Here is the parasympathetic effect. And here is the sympathetic effect. Sympathetic effect. This is the pupillary dilated muscle, radial. There is the radial fibers, and there is circular or sphincter fibers. Okay. The pupillary constrictor muscle supplied by and makes the pupil constriction. This more details. Supplied by parasympathetic. So when it's parasympathetic active, it makes constriction of the pupil. It will make constricted pupil. Okay. The radial pupillary dilated muscle supplied by sympathetic. When it is active, it pulls the eye outside the pupil to make dilated pupil. So keep dilated or dilator, sympathetic. Constrictor, parasympathetic. In head trauma, the parasympathetic goes with oculomotor nerve, carried over the oculomotor nerve. Tamam?
Yeah.
When in eye trauma and there is brain herniation or tentorial herniation or coning or whatever the expression about the brain herniation, okay, there is compression of the oculomotor nerve and it will compress together مع parasympathetic will be compressed. What will be overactive?
Dilated sympathetic.
Sympathetic will not be overcome by the parasympathetic. We completely abolish the parasympathetic. So sympathetic will act alone. Sympathetic when act alone will make dilatation of the eye. As we see here, like we are making like equation. As you go toward parasympathetic, it will make constriction. As you go toward sympathetic, you will make dilatation. So parasympathetic, constrict. Sympathetic, dilate. So dilated fixed pupil means overact of sympathetic or abolishing of the parasympathetic carried on the oculomotor nerve. Clear?
Yes, no, great. Thanks for this explanation.
Okay.
A 32-year-old mountain bike presented with the outpatient clinic. He felt awake weirdly with excessive lateral deflection of the neck to the left side. He described some paresthesia over the right shoulder of the left arm, which appear to have improved over the past hour. What is the most likely injury suggest of this? So it's improved for hours. So it is axono and neuropyroxia.
What do you expect? What do you accept here? The patient has hyperlateral flexion of the neck.
Yeah.
What do you expect? C5 or T1?
C5.
C5. So you are searching for C5.
Yes.
Okay. So what is it? The patient has been improving over the past hour. So what it will be? Neuropraxia, axontemesis, or neurotemesis?
It is neuropyroxia.
Neuropraxia. So this will be our answer. Clear?
Yes, it's clear.
Clear. Okay. Neuroaxontemesis and neuropraxia and neurotemesis has a very long improving, sometimes not improving, especially with neurotemesis. It can take years. It can take years, and sometimes there is no improvement. But neuropraxia is just trauma or concussion to the nerve. It will be improved by time, within few hours. Okay, next question.
62 years old woman presented with the firm irregular mass in the upper outer quadrant of the right breast. The appearance malignant on the mammograph. On the fine needle aspiration cytology and report C5. Which of the first lumbar, which is the first lymph node is to which the tumor is most likely to metastasize? Initially node, primary node, secondary node, sentinel node, vertical node. It's D.
Central lymph node. Central lymph node is the first lymph node to any tumor metastasize. Next question.
50 years old woman presented with the history of the fecal incontinence over the past few years. She is prolonged and difficult first stage labor. 20 years previously, physical examination revealed relatively lax of the anal sphincter, which was likely have damage to this pudendal nerve. E.
So your answer is epidendal nerve. This repeated question. Next question.
26 years old man presented to the emergency department with extensive bleeding from his arm after sustained glass injury. On examination, there is the 7 cm transverse laceration across the anterior aspect of the elbow joint. On the exploration of the cubital fossa, you would expect the brachial artery to be? Anterior to the median nerve? No. Lateral to the biceps? No. Lateral to the median nerve? Yes. Medial to the median nerve? Superficial. So it is C.
I think Dr. Rami's mic is muted.
I'm sorry. My mic is muted. Okay, again. Always play with these nerves with the brachial artery. Median nerve, most common. And he asked about the full course, lateral, anterior, medial, or he asked about only on the cubital fossa. It will be medial. Sometimes asks the brachial artery to the median nerve, or sometimes asks the median nerve to the brachial artery. The exam need concentration. This is the relation of the nerve to the artery, median nerve to the artery, lateral, anterior, medial. In the cubital fossa, only medial. Okay? If the artery to the nerve, it will be lateral. So one time he brings the ulnar nerve. Ulnar nerve is always medial. Okay, to the artery. Always medial to the artery. Okay? Next question.
53 years old man complain of crushing chest pain. On the rest, he has chronic hypertension and heavy smoking. His pulse rate 138 beats per minute and blood pressure 140/90. What is the principal cause underlying reduce the coronary artery blood flow? Decrease cardiac muscle wall tension, decrease coronary oxygen extraction, decrease diastolic interval, decrease systolic interval, decrease vagal tone. Let's see.
Decrease
Diastolic.
diastolic interval. Filling of the coronary artery is only during diastole. Okay.
Yeah.
All the vessels filling during systole and blood supply during the systole, except the coronary. It is filled and gives the blood supply to the heart during diastole. Okay.
Okay.
Very important when you have this patient. Sometimes that's why patient with tachycardia. Sometimes you're scared from ischemia or decreased blood supply. If the patient has a relative ischemia, so you can be scared this patient may have a MI or something like this. So this patient, you have to reduce the heart rate to give the patient opportunity and during the diastole to have a blood supply to the heart. Where is the site of the coronary artery? Very common question.
Anterior to the coronary vein. Sinus. Anterior or posterior? Left, right anterior, or left posterior?
The right coronary artery, or whatever they're asking, the right coronary arteries. The most common question came in the exam, and especially it came also in April 2018. April 2018 is above the valve. Okay, always below the valve, above the valve, posterior, this will be anterior. The right coronary will be anterior and above the valve. Above the valve because it takes blood supply during diastole. Closure of the valve during diastole, and this will be open and this will take its blood supply. We will face this question during recalls. Okay, next question.
58 years old woman, a known patient with thoracic right side meningioma, presented with the feature suggested of Brown Square syndrome. The clinical finding would include which of the following? So it is in the right side, left side weakness, and left side proprioceptive and vibration loss, right side loss of the pinprick sensation, right side weakness, right side proprioceptive vibration, left side the patient has pinprick loss, right side weakness, right side proprioception and vibration, right side loss of the pinprick, right side weakness of the left side proprioception and vibration, right side loss of the pinprick, left side weakness, right side proprioception and vibration loss, left side loss of the pinprick and sensation. So we need to choose. It is right knee weakness, proprioceptive vibration, left side pinprick. D.
What you choose?
D.
D.
Yeah.
Right side weakness, left side proprioception and vibration, right side loss of pain and prick sensation.
It's either B or B. Either D or B.
Anyone has different answer?
B.
B. Who said B?
Me. I struggle between.
Okay. Okay. Why did you choose D?
Because there is some lesion in the right side and the other in the left. in the contralateral, ipsilateral.
Okay.
Ipsilateral.
The weakness, the motor weakness, or of the corticospinal tract and the dorsal column, go from the ipsilateral. Okay, pain and temperature will be from the contralateral. Okay, to understand what will happen, I always like to do this. Okay. Okay, you have this is the spinal column. Okay, just have a midline here. This is the corticospinal tract. Nerves from the corticospinal tract. Let's make it here. This is the vein. This is the brain, the crossing in the medulla. Okay, that's all. And this is the target organ, maybe this one and this one. Okay, corticospinal tract is here. Dorsal column is here. Pain and temperature also is here. Okay, what happened from the sensation, from the motor? The motor, what happened like this? You have a motor, fibers from here, go direct, ipsilateral, and still go ipsilateral in the cortical, in the decussation, in the medulla, and cross to the other side to go for the brain to the other side. But decussation will happen in the medulla. Okay? The same for the proprioception and vibration. Come like this, go for proprioception and in and up, and decussation happen up and go to the ipsilateral. Here, the end of the spinal cord, or the start of the spinal cord till down. Pain and temperature. I'll make also this side. Pain and temperature this side. Pain and temperature go to the spinal cord and go for one level up and then cross and go to this side. Just one level up, and it go and ascend for one level and then cross down in the spinal cord. Cross down in the spinal cord and then ascend. Okay, and if I have the same like here, so it will go up, cross, and go here. If I have a cut here, what will be affected? There will be affected the ipsilateral motor, the ipsilateral proprioception, and the decussated fibers of the pain and temperature from the other side. But from the same side, it is already decussated. Okay?
Okay.
So you will have loss of motor here. You have loss of proprioception and vibration, which is the deep sensation, but pain and temperature will be on the other side. So you'll find the man like this. You have the trunk like this. And this is the decussation. Anyone will happen, he will have this half. This will be loss of here. One level below the injury, by the way. One level below the injury. Here he will have loss of movement or weakness, plus loss of deep sensation, which is proprioception and vibration. And on the other side, he will lose temperature. because this one fiber here for proprioception, one fiber here for proprioception, and the decussated fibers from pain and temperature, and I have my cut here. Hemisection or brown squirt syndrome of the cat. Clear?
Yes.
Yani forgive me because I like neuro so much, so that's why I know the neuroanatomy. Yani. Clear or difficult?
It's difficult. Neuro for me, it's difficult.
It's difficult.
Yeah.
I like neuroanatomy. Okay. So in brown squared, you have right weakness and right proprioception and vibration. You'll have the motor and the deep sensation will be on one side. And you'll have the pain and temperature on the other side. Pinprick means sensation.
Okay.
Pain sensation will be on the other side. This is the brown square.
Okay.
This one. Okay, next question.
Okay. 70 years old women.
Let someone start. Who's ready to continue? It's enough. And just take break. Ahmed is ready. Dr. Mu'tasim also ready. Where is Dr. Indo? Are you ready?
Yes, Dr. Remy.
Okay, so Dr. Mu'tasim, Dr. Indo, then Dr. Mu'tasim, then Dr. Ahmed and Dr. Dafir. Thank you, Dr. Mu'tasim. You are very active. Thank you. Okay, Dr. Indo.
Thank you, Dr. Rami.
Start.
Yeah. 70-year-old woman presents with a fractured left humerus. X-ray shows an osteolytic lesion at the site of the fracture. Histological examination of a sample taken at the time of internal fixation shows a metastatic carcinoma. Where is the most likely primary site? Breast, colon, endometrium, ovary, stomach. I think it is breast, doctor.
Jesus. Most common primary sites for bone metastasis is breast, lung, prostate. Okay. Keep this in your mind.
Sure.
So the answer here will be
A.
Breast. Breast is the most common.
And
If
also
man,
first
it will be.
And also first to osteolytic. The third one, prostate, it is osteosclerotic.
This is. Sorry. This is osteolytic.
Yeah. So it is the first
Okay.
one on the breast, osteolytic. And prostate,
Yes, this is osteolytic.
Okay.
If
osteosclerotic.
Osteosclerotic, it will be
Prostate.
the prostate. Okay, next question.
A 70-year-old man presents with a pulsatile swelling in his abdomen. The principal abnormality within the wall of arterial aneurysm is loss of adventitial collagen, adventitial elastin, intimal collagen, intimal elastin, medial elastin. this is medial elastin. Because the most frequent histological detectable lesion is medial degeneration.
Medial elastic degeneration or cystic medial elastic degeneration. They always keep this in arterial aneurysm. Most common cause is degeneration of the median or the medial elastic median. Yeah, median elastic tissue. Median elastic tissue. Very common, and this is, you have to know the definition of the aneurysm or the main cause or the most common pathology. The pathology of the aortic aneurysm, the most common is median elastic degeneration or median elastic necrosis. Very common. Okay.
Okay.
Next question.
A 24-year-old woman presents with a swelling in the thyroid gland. She also has enlarged lymph nodes in the left anterior triangle of the neck. Which of the following is the most likely diagnosis? Anaplastic carcinoma, follicular carcinoma, adenoma, follicular carcinoma, medullary carcinoma, papillary carcinoma.
We explained it in the start of our session. Patient with a lymph node means lymphatic spread. What you put in your mind for lymphatic spread?
Papillary carcinoma.
And
medullary.
And medullary carcinoma. What is here give you more medullary or more papillary? Papillary will give you nothing. Papillary, just a lymphatic or lymph node swelling plus thyroid swelling. And medullary, as I told you, he will give you a long scenario about family history, calcitonin, calcium, hypertension, or vinyl mandelic acid. Okay, يبقى lymph node مع thyroid swelling, it is papillary unless prove other side. What is the otherwise? Give you a family history. So you'll go for medullary. Please, very common question in the exam by difficult scenario. I told you all of these come in the exam, especially follicular, medullary, and papillary. Very common in the exam. Okay, next question.
A 20-year-old man with a severe head injury is being ventilated using positive pressure. Which of the following is a physiological consequence of this? Decreased extrafluid volume, decreased cardiac preload, increase in intrathoracic blood volume, increased cardiac preload, increased cardiac stroke volume. Positive pressure.
Fawzia Sheet 1, repeated question.
Decreased cardiac preload.
Decreased cardiac preload. As we explained simply, increase the positive pressure inside the thorax will decrease the intrathoracic blood volume and will decrease as well the cardiac preload and will decrease the stroke volume. Okay?
Okay.
Increase the intrathoracic pressure, or by another way, decrease the negative pressure of the intrathoracic negative pressure, will decrease the venous return, so will decrease the intrathoracic blood volume, so will decrease the cardiac preload, and eventually will decrease the stroke volume from the heart. And this is a problem of patient ventilated with positive pressure, whatever interrupted or continuous positive pressure ventilation. Okay, next question.
A 70-year-old man presents with a 1-week history of epigastric pain and profuse vomiting. The most likely consequence is hypochloremic acidosis, hypocalcemic alkalosis, raised serum chloride, raised urine sodium, reduced renin release. It is answer A, hypochloremic. I'm sorry, doctor, I couldn't figure out this. Dr. Rami, your mic is muted, I guess.
Yes. Okay,
Thank
sorry.
you, doctor.
What will happen? What will happen? Thank you, Dr. Endo. What will happen with profuse vomiting? What is the metabolic disturbance that will happen with profuse vomiting?
Dose of the
Metabolic
hydrochloric acid.
alkalosis.
I need just the metabolic, the metabolic disturbance.
Metabolic alkalosis, doctor?
Okay, keep this please in your mind and never forget in part A and part B. Profuse vomiting or patient with ships or patient with duodenal atresia, any patient with profuse will have hypocalemic, hypochloremic, metabolic alkalosis.
And aciduria.
Please, yes, this is paroxysmal paradoxical aciduria. This is a very big mechanism to understand, yani. Okay, but I want you to know this for part A. Hypokalemic, hypochloremic, metabolic alkalosis.
So
Clear?
the answer B. Yes, doctor.
So your answer is
B. Hyperkalemic alkalosis.
hypokalemic alkalosis. This is here also explained. The patient will have hypokalemia and will have hypochloremia. The patient will lose HCl and will lose hydrogen as well.
Okay. A 22-year-old man arrives in the emergency department with sudden breathlessness due to a large pneumothorax. An immediate chest drain is inserted into the 5th left intercostal space in the mid-axillary line. There is hemorrhage into the drainage bottle. Which of the following structures is the most likely cause of this acute hemorrhage? Intercostal artery, left pericardiophrenik artery, lingua of the lung, right ventricle of the heart, spleen. This is intercostal artery.
Intercostal artery is the most common cause of bleeding in chest tube is the intercostal artery because it is the most close one. Look to the picture. Intercostal artery is the most close artery in the intercostal space. Intercostal space. Okay, next question.
The right and left pulmonary arteries are derived from which of the following embryological aortic arches? Oh
yes, your answer direct على طول. Go for the answer.
Second pharyngeal arch, third pharyngeal arch, fourth pharyngeal arch, fifth pharyngeal arch, and sixth pharyngeal arch. This is sixth pharyngeal arch.
Sixth pharyngeal arch. I want you don't think about this question no more than 10 seconds in the exam. As we said, the most important is the second, facial nerve, stapedial, and stapes. The sixth is the right pulmonary or the pulmonary trunk and the ductus arteriosus. Okay?
Yes.
Pharyngeal arch, not pharyngeal pouch. Pharyngeal arch, not pharyngeal pouch.
Okay.
The most important. We talked before about the most important, and we see the second, the sixth, plus minus the first. Sometimes if asked about each with muscles of mandibular portion of the trigeminal plus muscles of mastication, and we said the second will be the seventh or the facial nerve, and we said the sixth will be the pulmonary trunk or ductus arteriosus. What's more important, this is according to the arch. If he asked about the pouch, more important for us, the third and fourth, and it will make like X. Third, it will be thymus and the inferior parathyroid. Fourth will be superior parathyroid. It will be X. Third will give B the thymus and the inferior parathyroid. The fourth will give B superior parathyroid. Third and fourth pharyngeal pouch are very important. Third, thymus. I always like to write it like this, plus inferior parathyroid. Then put the fourth up and make superior parathyroid. In the exam, you have question tell you, during this section, patient has, during parathyroidectomy, the surgeon didn't find the inferior parathyroid. Where did you expect to find them? Where do you expect to find the inferior parathyroid? With the thymus. With the thymus will be failure of ascent to the thyroid. They will be with the thymus, okay?
Okay.
So third, thymus, inferior, fourth, superior.
What about the aortic arch and pharyngeal arch?
Keep it pharyngeal arch. Sometimes aortic arch, but it's wrong. Who write it by wrong. This pharyngeal arch, branchial, the branchial arch, لا, keep the branchial arch different. The branchial, the branchial arch, keep it on one side. Keep in your mind pharyngeal arch and pharyngeal pouch. Arch and pouch. Okay. Next.
In the fetal circulation, the majority of blood passing from the inferior vena cava into the right atrium subsequently passes next into which one of the following?
Difficult question, this. Pediatric surgery or embryology, left atrium. Left atrium. Fetal circulation, majority of blood passing from the inferior vena cava into the right atrium, subsequently pass next through the foramen ava. This is the blood coming through the IVC, go right atrium, foramen ova, left atrium, foramen oval, left atrium. From the left atrium, go to the left ventricle, then the aorta, then continuous circulation. Okay. Clear?
Yeah, doctor.
Clear, okay. So keep it from the left through the foramen ovale. That's why the foramen ovale, from the right atrium to the left atrium. Next question.
A 36-year-old butcher injures his left index finger with a knife, suffering a deep laceration on the palm aspect of the middle phalanx. On examination, he is unable to flex distal interphalangeal. Which tendon is likely to have been injured? It is distal, then flexor digitorum profundus.
Exactly. Repeated since yesterday. Profundus, flexor digitorum profundus affect the distal phalanx, or flex the distal phalanx. Next question.
A 39-year-old woman with large expanding ovarian mass that is removed surgically, requiring a lateral pelvic wall clearance of lymph nodes. 4 days post-operatively, she complains of painful spasm in the groin area and remarks that she has an area of numbness on the medial side of her thigh. The most likely explanation for these problems is that during surgery, an injury was inflicted on the femoral nerve, genitofemoral nerve, lumbar sacral trunk, L3 ventral ramus, obturator nerve. Sensory. Obturator nerve.
Obturator, yeah. Very common question in the exam, by the way. Obturator nerve supplying this small area, the medial side of the thigh, and affected within ovarian mass. And we have two types of question in this. The patient during a dissection of an ovarian mass, the patient kicks with her leg or moves with her leg. Which nerve did you excited, or did you touch? The obturator nerve. Supply which muscle? The obturator nerve.
Obturator nerve supply medial part.
Adductors.
Yeah.
Adductors. So it is very common to touch this nerve during pelvic surgery and very common during ovarian surgery. Sometimes the patient kicks with her leg due to excitation of the adductor muscles. Which nerve has been elicited will be obturator nerve. The patient has, after operation, the patient has area of numbness on medial side of the thigh. Which nerve has been excited or elicited or injured? It will be the obturator nerve. Very common with the ovarian surgery. Ovarian obturator. Ovarian obturator. Next question.
A 70-year-old patient is found to have sodium of 125 millimoles on examination. There is no signs of hypovolemia. His plasma osmolarity is 280 and his urine osmolarity is 1000. Which of the following is the best explanation of these findings? Central diabetes insipidus, cerebral salt wasting syndrome, nephrogenic diabetes insipidus, syndrome of inappropriate antidiuretic hormone secretion, and water deprivation.
It's difficult question about physiology and hypo and sodium metabolism, plasma osmolarity.
Answer is SIDH.
Yes, exactly. Sciada. But in the exam, if you are confused about this, he likes sciada in the exam. He likes sciada in the exam, and he likes sciada. Urine osmolarity is low. This is urine osmolarity and plasma osmolarity, and there is no signs of hypovolemia. The patient found to have sodium off. This is hyponatremia. The patient has hyponatremia because there is a preservation of the water in our antidiuretic hormone, so there is much water preservation in the body, so the patient will have hypoosmolarity or hyponatremia. This hyponatremia with eovolemia will be sciada. Hyponatremia with eovolemia will be sciada. If you go for let's keep this. Always the patient is eovolemic. Decrease the serum osmolarity. Okay, place 280. Eovolemic, and the patient has hyponatremia. This is the most important about sciada. Normal sodium will be 135, this 145. So this is 125. So the patient has a low sodium. So this is hyponatremia. Hyponatremia with eovolemia equal sciada. Next question.
A surgeon is carrying out an elective splenectomy for congenital spherocytosis. Which structure will be divided in order to mobilize the spleen from the posterior abdominal wall? Gastrosplenic ligament, lesser omentum, linorenal ligament, phrenicocholic ligament, short gastric vessels. From the posterior abdominal wall, it must be gastrosplenic ligament, doctor. Oh, sorry. It is splenorenal ligament. Answer C.
This is the abdomen, okay?
Yeah.
This is the abdomen. This is the stomach. And this is the kidney. The spleen has two ligaments. When you open, this is the anterior abdominal wall. When you make incision, midline incision for a splenectomy, you pull on the stomach to expose this one. This is the lesser sac. This is the lesser sac. Okay? This is the lesser sac. You pull this stomach, you pull on the fundus of the stomach to expose short gastric vessel or the gastrosplenic ligament. So this is the gastrosplenic ligament. You have to cut to start your operation. If you didn't cut, you can't go, because in the renal ligament, which is this one, run the splenic vessels here. Okay?
Okay.
You have to cut this containing the short gastric vessel. Gastrosplenic ligament has the short gastric vessels. Okay? You have to ligate and cut. So you exposed the pedicle of the spleen. Clear? You expose the pedicle of the spleen included in the lieno-renal ligament. So the lieno-renal ligaments contain the splenic vessels. The gastrosplenic ligaments contain the short gastric vessel. In order to reach the posterior abdominal wall, you have to cut this to access the spleen. So the first anterior layer you have to divide, to cut in splenectomy is the gastrosplenic ligament containing the short gastric vessels. After you ligate and cut and you pull the stomach out, this field will be clear. So you can hold this with a clamp. You can hold a clamp here and a clamp here and cut in between. So you ligated the lieno-renal ligament, including the splenic pedicle, which is the splenic vessels. And very common structure here you can injure, which is it? What you can injure? Anyone can answer me, please? Anyone? Dr. Dafer, Dr. Mu'tasim, Dr. Ahmed Aziz.
The commonest artery to be injured during
Structure
this
to be injured during splenectomy.
tail of pancreas.
Exactly. If he ask you the commonest structure to be injured or a structure during splenectomy, it will be tail of pancreas, because it also passes with the splenic vessels through the lieno-renal ligament. That's why you have to cut direct on the pedicle, not to injure the tail of pancreas. Okay.
Okay.
This is if he asks you generally. If he make or choose one of the ligaments, so if he said in the gastrosplenic ligament, the structure to be injured, it will be fundus or whatever he will tell you, fundus or greater curvature of stomach. Okay. Lieno-renal will be tail of pancreas. This when you sometimes this is, by the way, this is short gastric vessels. Sometimes it's very short. Yani you have to just put a clamp here and the clamp here to cut. Sometimes this clamp make injury to the fundus of the stomach. And if you are doing emergency operation and the patient has big hematoma here, yani it is sometimes the hematoma cover part of the stomach through the short gastric vessels. So you hardly can see the wall of the stomach. So if you injured something here, it will be the fundus of the stomach. If you injured the most common, or you injured something in the lieno-renal ligament, will be the pancreas. Clear? So this is lieno-renal ligament. Posteriorly, lieno-renal ligament. Posterior abdominal wall, lieno-renal ligament. Next question.
A 45-year-old man has established post-hepatic cirrhosis. At a follow-up appointment, a palpable spleen 4 fingers breadth below the costal margin is noticed. Full blood counts have shown a persistent thrombocytopenia. Bone marrow examination has shown megakaryocytic hypoplasia. What is the most likely cause of the thrombocytopenia? Ineffective production of bone marrow, platelet destruction in the bone marrow, platelet destruction in the liver, platelet destruction in the spleen, platelet storage in the spleen.
What is the main cause? Hypersplenism. What is the main cause of thrombocytopenia and megakaryocyte hyperplasia? Trying to compensate the thrombocytopenia.
Platelet destruction in the spleen.
Perfect. Yes. Repeat it from the sheet 1. The spleen, the hypersplenism, and the splenomegaly make destruction for the platelets. The patient have thrombocytopenia, and at the same time, the patient has hyperplasia of megakaryocytes, which produce the platelets. Okay, next question.
A 7-year-old boy presents with recurrent attacks of pneumonia. Culture showed Pseudomonas aeruginosa. His mother confirms that he had Meconium Alias in the neonatal period. Which of the following is the most likely finding in this boy? Increased sweat chloride test.
Yes. Increased sweet chloride. And the test is sweet chloride test. Meconium Alias. So the patient has cystic fibrosis since his childhood. This patient in cystic fibrosis will be some sort of absence of cilia. So this patient will have recurrent attacks. This patient of cystic fibrosis will have recurrent attacks of pneumonia and chest infection. Together, he will give history of Meconium Alias during his neonatal life. So this patient has cystic fibrosis, and increased sweet chloride. And if you want to ask what is the best test, it will be sweet chloride test. Sweet chloride test. Okay?
Okay, doctor.
Next question and last question.
A 42-year-old man has a cholecystectomy and develops a self-limiting post-operative wound infection. By what process would bacterial ingestion have been enhanced?
Repeated question. Ingestion of bacteria, bacterial ingestion will be with which process?
Phagocytosis?
No. Opsonization. Bacterial ingestion with opsonization. Okay. Thank you, Dr. Endo.
Thank you,
Who's ready after Dr. Endo? And we will take just 5 minutes break, please. Okay, back again to continue our session. Okay.
Yes.
Yalla start, Dr. Ahmed.
After resection of the renal tumor, a patient experiences erectile dysfunction, which is a nerve is most likely to have been damaged in the surgery. Due to femoral nerve, lumbosacral nerve, pelvic splenic nerves, a peroneal branch of S4 pendular nerve. This is a repeated question. Is splenic plexus, pelvic splenic nerve, number C.
Pelvic splanchnic nerves. Pelvic splanchnic nerve is the most common injury during patient rectal or sometimes during prostatic resection. Pelvic splanchnic nerve containing the hypogastric or hypogastric plexus responsible for the erectile dysfunction. Next question.
Yes. 15-year-old girl has been treated for tuberculosis over the previous 6 months. She presented to her doctor with a fatigue, loss of appetite, and weight loss. On examination, her blood pressure is 90 over 55. She has increased pigmentation. What is the next most appropriate investigation? Aldosterone, oral glucose tolerance test, random cortisol, ACTH stimulation test, water deprivation test. Number D, test for ST It's a stimulation test.
Okay.
For Addison disease.
Okay, this Addison disease, and we do it with the ACTH stimulation test. ACTH stimulation test to test for Addison disease. The patient has increased pigmentation, and increased pigmentation, one of the keywords here you have, and she has a low blood pressure. Okay, low blood pressure, pigmentation.
Yes.
This is a picture of Addison disease. Addison disease, we have to do ACTH stimulation test. Next question.
Yes.
Hello. Next question, Doctor.
Repeated question, Dr. Rami. Tough, right?
Which one?
73-year-old man with. Yes, from hearing you. Yes, I'm hearing you.
Okay.
133. 133.
Okay.
Yes.
Continue.
73 years old man with history of irregular bowel movement, presented with dysuria, pneumaturia, and Escherichia coli urinary tract infection. CT scans show a mass involving the sigmoid cord.
Was this a repeated question since yesterday?
You can hear me?
Yes, repeat, your voice go and come in, by the way. Okay, I can hear you good now. This is the repeated question.
Yes, this is a diverticular.
Okay, next question.
CT scan show mass involving the sigmoid cord and the bladder. The commonest. Yes.
Next question, Doctor.
30 years old man is
Dr. Ahmed, you have a problem in your voice.
The fracture at the in the fracture side. You have been. Okay, Dr. Mu'tasim can go. Sorry.
طب دكتور معتصم معلش انا اسف دكتور احمد. Try to go for a good place with connection. Dr. Mu'tasim, start.
Okay. A 30-year-old man is assaulted with a hammer and sustains a depressed fracture at the vertex of the skull. Profuse venous bleeding is noted at the fracture site, which vascular structure is most likely to have been perforated. Cavernous sinus, inferior sagittal sinus, sigmoid sinus, superior petrosal sinus, superior sagittal sinus. Answer is E, superior sagittal sinus.
Superior sagittal sinus, the same, like you can see the picture. Superior sagittal sinus will be in the vertex, most common to be injured. Next question.
57-year-old heart transplant recipient is keen to join the cardiac rehabilitation program. Which of the following factors is most likely to increase cardiac output in this patient during a moderate exercise? I think it is increased atrial filling. Answer is D.
Repeated question from sheet 1. Okay, in transplanted heart, rehabilitation program depend on the how to increase the cardiac output by increase atrial filling. Okay, next question.
An 18-year-old woman fell 9 meters while rock climbing. She had a renal transplant 2 years ago. She is brought to emergency department for resuscitation and appropriate analgesia is given. When correctly prescribed, which of the following analgesic drugs would be most likely to be adversely affect her renal function in this situation? Diclofenac, dihydrochloroquine, morphine, paracetamol, tramadol. I think it is diclofenac.
Diclofenac. Look to the picture here. The renal afferent vessels depend mainly on prostaglandins as a vasodilatation or a normal vessel to permit normal blood flow to the glomeruli. Keep here, here. Normally, prostaglandins keep the afferent vessels patent and have a good blood flow for the glomerulus. Okay, on the other hand, the other side is angiotensin 2. Angiotensin 2 acts on the efferent effect. When you have NSAIDs or COX-2 inhibitors, it will abolish the action of prostaglandins. It will make a vasoconstriction of the afferent vessels of the glomeruli. Afferent glomerular vessels, the afferent arteriole will have vasoconstriction, so it will decrease the blood supply to the glomeruli, it will decrease the glomerular filtration rate. So that's why we say always that non-steroidals on the long run can cause a problem in the kidney, and we can see it in many patients with borderline kidney problem. When they take non-steroidal for a long time or for high dose, they can go for acute renal failure. Next question.
A 77-year-old man is admitted with acute urine retention, secondary to benign prostatic hyperplasia. A urinary caster is inserted and has free flow of concentrated urine. Which of the following best accounts for the action of the counter-current
multiplier
mechanisms that leads to concentration of urine in loop of Henle? Counter-current multiplier mechanism, active transport of solute out of thin section ascending limb, impermeability to water in thick ascending limb, permeability to solute in descending limb, permeability to solute in thick ascending limb, permeability to water of thin section ascending limb. Counter-current, it is thin ascending limb, thick ascending limb. Counter-current multiplier mechanism. Ascending is a counter-current in the thin section of the ascending limb.
Just briefly to understand what is a counter-current, because this question has a confusion and debate between different mentors and different and answered by different ways. Okay. For me, what is a counter multiplier mechanism? Simply that here during descent of urine, there is a free permeability of water here in the descending limb. Descending limb has a free permeability to water, but impermeable to solutes. On the ascending limb, there is active transport of solutes, but it is completely impermeable to water. Completely impermeable to H2O. So here is free permeable to H2O. Here is impermeable to H2O. And active transport of solutes. Okay, how to concentrate the urine here? Concentrate the urine. Some acts makes this impermeability to water in thick ascending limb. It is completely right. So here he asks about concentrate which of the following action counter-current mechanisms: concentration of urine. Concentration of urine. Permeability to solute in the thick ascending limb has some sort of, this is inaccurate. Because here he mentioned active transport. Okay, so he needs here to tell you there is difference between active transport and permeability. Active transport solute is thin section of ascending limb. No, not thick section, in the thick ascending limb. Here will be right if there is active transport of solute in the thick ascending limb. If this is active transport, if this is active transport, I can consider it right. But permeability, I have this is more accurate. Permeability to water in the thick ascending limb, impermeability, this is completely right. This is completely right. So you'll find some answering it. You'll find some answering it. D. Others answering it. B. B. Impermeability to water in thick ascending limb. For me, it's completely right. Here, in this part, I object on this permeability. If it is active transport, for me, it will be better. Okay?
Okay.
Because here, in the thick ascending limb, there is active transport of solute and impermeability of water. So for me, B is more wrong. Okay, more right. Keep this and you'll find different mechanism about it. Okay. If you read this, can you read this, please?
The counter-current multiplier system at loop of Henle, active salt transport out of water impermeable thick ascending limb establishes an horizontal gradient of about 200
milliosmolar.
200 milliosmolar
okay.
between the tubular fluid and the medullary interstitial fluid.
Okay, so here, active salt transport of the water impermeable thick ascending limb. This is more accurate for me. This is more accurate for me. Okay, next question.
Okay. A 52-year-old man is found
Repeat
to
the
have
question.
multiple myeloma. Skull X-ray would be characteristic of multiple osteolytic lesions.
Okay, next question.
A 56-year-old man undergoes resection of his ileum secondary to ischemic bowel. Which of the following effects is most likely to be seen in this patient post-operatively? Decreased bile salt synthesis by liver, decreased the concentration of bile salts and colonic content, decreased mean corpuscular volume, decreased the absorption of vitamin B12, decreased stool frequency. Patient undergoes resection of his ileum. So decrease bile salts, decrease concentration of bile salts, decreasing, I think, decreased absorption of vitamin B12.
Exactly.
Okay.
Decreased vitamin B12 absorption. Okay.
Okay.
Next question.
A previously healthy 45-year-old woman undergoes emergency splenectomy following a traumatic rupture of the spleen. A left subclavian central venous pressure catheter to guide fluid therapy is inserted. At this time, she becomes distressed and acutely dysnic with a blood pressure of 75/40 millimeter mercury. There are decreased breath sounds on the left. Her temperature is 35.5 degrees Celsius. What is most likely cause? Acute blood loss, anaphylaxis, myocardial infarction, sputum retention, tension pneumothorax. I think it is tension pneumothorax due to injury of apex of the lung.
Exactly. Injury of the pylore. This is very common with the when you go for CVP. And that's why after doing CVP, patients would have to go an X-ray chest to make sure there is no pneumothorax. Next question.
During the second phase of wound healing, the predominant cells in the wound sites are fibroblasts. This cell is of mesenchymal origin and produces the matrix and the collagen needed to strengthen the scar. Cross-linkage of collagen requires the hydroxyproline and hydroxylysine residues, which requires a specific vitamin to be available in sufficient quantities, deficiency of which vitamin results in collagen that is unstable, vitamin C.
Exactly. Vitamin C, repeated also. Next question.
A 19-year-old man fell down a flight of stairs on presentation to emergency department. His Glasgow
Hello. معتصم. Hello. Anyone ready to continue? Hello. My voice clear? Anyone in my voice clear? Screen is still clear? Can one answer me, please? So the problem with me or with Anna? Dr. Ahmed?
Clear, sir.
Hello.
Yeah. Yes, Dr. Mu'tasim. Okay.
Can you
Repeat
can you
again.
hear me?
Yes, that's okay.
The answer is the left-sided extradural hematoma.
Tab, can you read the question again, please? Dr. Mu'tasim, can you read the question again because we couldn't hear it?
Okay, a 19-year-old man fell down a flight of stairs. On presentation to the emergency department, his Glasgow coma score was 14/15 with no local neurological signs. An hour later, he vomited and his Glasgow coma score deteriorated to 10. He developed a fixed and dilated left pupil. Which of the following is likely to be seen on the scan? Left-sided acute subdural hematoma, left-sided extradural hematoma, left-sided midbrain hematoma, right-sided acute subdural hematoma, right-sided extradural hematoma. I think it is left-sided extradural hematoma.
Left-sided extradural hematoma, compressing on the which nerve?
Oculomotor.
Oculomotor nerve and the parasympathetic
And the parasympathetic
innervation, causing fixed dilated pupil on the left side. Okay, next question.
A 70-year-old woman weighing 50 kilogram undergoes open cholecystectomy. Post-operative pain relief is administered by intravenous morphine infusion. Morphine 1 milligram, 5-minute lockout. 24 hours post-operatively, she is in an agitated, confused state. Her temperature is 37.1 degrees Celsius, pulse 90 beats per minute, blood pressure 110/90 millimeter mercury. Her urine output is 35 milli per hour. Arterial blood gases are pH 7.27, oxygen tension 9.6 kilopascal, CO2 tension 10 kilopascal, bicarb 29 millimole per liter, base excess -6. Which of the following is most likely explanation to account for false find? Best explanation to account for false findings. Hypovolemia, opiate-induced hypoventilation, pain-induced hyperventilation, pulmonary embolus, silent myocardial infarction.
What is the pH, the metabolic disturbance here?
Metabolic disturbance is respiratory acidosis.
Respiratory acidosis. Compensated, not compensated?
Not compensated. Bicarb is mildly elevated.
So it is partially or completely compensated?
Partially compensated.
partial network compensate يبقى partially compensated respiratory acidosis.
3 acidosis.
CO2 high and PO2 and O2
Low.
is low.
Low.
So what you expect this is to be?
Hypercapnia, hypoxia, type 2 respiratory failure.
Type 2 respiratory failure. What in the scenario can make respiratory failure with this?
Morphine.
Okay, so your answer will be?
Opiate-induced hypoventilation. But
Exactly.
the question asks which of the following is most likely explanation to account for false findings. What is meaning of false findings? The last
Which of
before
the following
options.
most likely explanation to account for?
I didn't understand what is the meaning of false findings.
For these findings,
For these findings, okay.
For me, here for these findings. For these findings. The patient give you that the patient has a respiratory failure, respiratory acidosis, so it will be opiate-induced hypoventilation.
Okay.
Opiate-induced hypoventilation.
Next question. A 70-year-old woman from nursing home is brought to the emergency department with abdominal pain and vomiting. On examination, she is dehydrated and her abdomen is distended. There is a 3 cm by 4 cm swelling in the right groin, which is non-tender, and there is no cough impulse. At operation, femoral hernia is found. Which one of the following lies immediately lateral to the hernial neck? Femoral artery, femoral nerve, femoral vein, inguinal ligament, pectineal ligament. Femoral vein.
Femoral vein, very common in the exam. Femoral hernia, ask about everything of the boundaries. Next question.
Next question. A 64-year-old woman is reviewed in the emergency department with an acute right groin swelling below and lateral to the pubic tubercle. Which of the following forms the medial boundary of the ring through which this hernia is protruding? Conjoint tender, inferior epigastric, inguinal ligament, lacunar ligament, pectineal ligament. It's lacunar ligament.
Medial boundary is?
Lacunar ligament.
Lacunar ligament. Lacunar ligament. Okay. Next question.
A 27-year-old has had pancreatitis for the last 5 years. Which one of these complications is the least likely to develop? Arthritis, cholangitis, iritis, polyarthritis, toxic megacolon. I'm always confused in this question. I don't know what is the least likely to develop. Polyarthritis.
What this patient have?
Ulcerative colitis.
Inflammatory bowel disease, whatever.
Inflammatory bowel disease, yes.
Inflammatory bowel disease. No relation to the arteries, no problem in arteries, no problem in arteries in patient with inflammatory disease. Remember, patient with inflammatory bowel disease, he'll have an elbow and knee joint and back pain. Elbow, back, and knee joint pain. So he will have polyarthritis.
Polyarthritis, not polyarthritis.
So it is not polyarthritis. Patient, if you know a patient in your life with inflammatory bowel disease, he will always have back pain, knee pain, elbow pain. So the patient has polyarthritis, but has no relation to polyarthritis. By the way, this question may be repeated every exam.
Okay.
Next question. I hope you don't forget it again. Next question.
I will never forget it. An 82-year-old woman had a hemiarthroplasty of the hip 6 hours ago. She is an insulin-dependent diabetic and has been on long-term non-steroidal analgesic. In the last 3 hours, she passed via her urinary caster a total of 20 ml of urine. Her pulse rate is 120 beats per minute and regular. Her blood pressure is 100 over 60 millimeter mercury, and the capillary refill is 3 seconds. Blood urea and electrolytes are sodium 135, potassium 4, creatinine 140, urea 12 millimole. The most likely cause of this is acute tubular necrosis, blocked urinary caster, diabetic nephropathy, non-steroidal anti-inflammatory drugs, reduced renal perfusion. So patient she is an insulin-dependent diabetic, term non-steroidal. I think it is diabetic nephropathy.
Okay. This question is also confusing. All these can use, you have high creat and high urea. So the patient has decreased renal clearance, glomerular and renal glomerular filtration rate. Okay, the patient has high creatinine, high urea. So the patient is diabetic. So the patient can have a diabetic nephropathy. But no, not all patients have this, because here is tell you the patient has tachycardia. If you go for diabetic nephropathy, so you ignored what is mentioned here, that's tachycardia and low blood pressure. Capillary refill is normal. So you don't have to ignore these data. These data can give you two things, and oliguria as a and oliguria. You can't ignore these data. So
I think it is reduced renal perfusion.
This is the most, by the way, I talked to many nephrology consultants and many in different places, even in our university hospital, and many nephrologists and urologists about this. A little bit confusing. This patient, if we say the reduced renal perfusion, but I have what's called the renal perfusion can adjust and keep normal glomerular filtration rate up to 80 systolic blood pressure. If you can remember yesterday what we said, renal autoregulatory mechanism can adjust up to from 160 to 80 systolic blood pressure. So if 160, the renal can adjust. If 80, the renal adjusts. Within this limit, the glomerular filtration rate should be normal.
Okay.
So even if this blood pressure is 100, so there is no reduced renal perfusion. There will be normal renal perfusion. I doubt first about non-steroidal, because non-steroidal will decrease, as we explained 2-3 questions before, that will make an afferent arterial vasospasm to decrease the renal perfusion as something like non-steroidal anti-inflammatory, something acute on top of chronic. Acute on top of chronic, because not only this will affect. If the blood pressure is normal, capillary refill is normal, 3 seconds. So why capillary refill is normal? And I say the reduced renal perfusion. If there is the reduced perfusion here, will be reduced perfusion here. So capillary refill will be 4 or 5 or 6 seconds, right? The perfusion here will be the same like perfusion here. For me, I doubt this answer. Non-steroidal, because this is superimposed and will affect the afferent arteriole, but will not affect the capillary fill.
Yes.
Because this is specific for the afferent renal artery.
Yes.
Some ask it why not diabetic. Not all diabetic patients have a renal decreased renal blood perfusion. Blocked catheter, no. Still we have acute tubular necrosis, no. So confusion between this and this. For me, if I'm the exam, I write this. I sent it for many yani doctors and professors and the university. No one confused. Some say this. When I give them what is the renal perfusion or renal autoregulation from 160 to 180 systolic blood pressure, even the blood pressure is 80/50 or 80/40, the renal perfusion will be still good because the kidney can autoregulate. So how here? 100/60, okay, the kidney can autoregulate, so there is no decrease in renal perfusion. But this can affect, and this can affect locally the kidney and can affect and not affecting the capillary fill. Clear?
Clear, Dr. Rami.
So this confusing question as well. For me, I'm choosing non-steroidal anti-inflammatory which has a local effect in the afferent glomerular arterioles, so it will decrease the renal perfusion only, but it will not affect the capillary fill. And at the same time, this blood pressure doesn't decrease the renal perfusion. Okay, so have your choice between this and this. This may be right and this may be right. This is part of also a confusing question. Yalla, next question.
Which single respiratory test parameter, forced expiratory volume, in 1 second, is the best prediction for morbidity and mortality after surgery? Confronted flow volume loop, forced expiratory volume 1 below 1 liter, forced expiratory volume 1 over forced vital capacity below 70%, maximum inspiratory volume less than 2 liter, reduce the residual volume.
The most important, if we, I talked to one pulmonologist about this, and he said in fitness, patient has a COPD or patient has a pulmonary problem, fitness pre-surgery, we ask about this. Okay, by the way, it was answered wrong for a long time, for 2-3 years like this. But FEV1 or FVC should be less than 50 to predict morbidity and mortality. But the only parameter they ask for a patient have a pulmonary problem pre-operative, they asking about the forced expiratory volume in 1 second. If it is less than 1 liter, there is high risk. So answer is
B.
Forced expiratory volume less than 1 liter. Correct this question if you read Fawzia sheet from any other source. This is the right answer. Next question.
Next question, a 58-year-old man admitted for inguinal hernia surgery is found to have an enlarged heart shadow on his chest radiograph. Which one of the following statements is true of the right ventricle? It has a muscular wall that is normally thicker than of the left ventricle. No, it is wrong. Form is the apex of the heart. It is wrong. Form is the right border of the heart. It is directly related to the diaphragm, gives rise to the aorta. It is directly related to diaphragm.
Okay, right border of the heart will be right atrium, not the right ventricle. But it is completely right here. Directly related to the diaphragm is the right answer. Next question.
A 67-year-old The old man is admitted to hospital for investigation of irregular heartbeat. The conducting system of the heart includes which one of the following anatomical structures? Atrioventricular node, chordae tendineae, fibrous skeleton of the heart, interatrial septum, phrenic nerve. Atrioventricular node.
AV node, conducting system of the heart. The AV node, SA node and AV node and Purkinje fibers.
Okay.
SA node, AV node and Purkinje fibers. This is the conducting system of the heart.
Okay.
Next question.
A 28-year-old man is found in the sea by emergency services. He is alert but confused. His core temperature is below 33 degrees Celsius. Ecg changes that may occur include which one of the following? Atrial flutter, inverted T wave at the junction of the QRS and the T wave, narrow QRS complex, prolonged PR interval, short QT interval.
What does this patient have?
Hypothermia.
Hypothermia. What do you expect in hypothermia?
J wave.
What else? Prominent G wave.
I don't know.
Prolonged PR interval. Okay, I forget to put a picture for it, but okay, if you search for hypothermia, you have a prominent G wave. Okay, or prolonged PR interval. Next question.
A 75-year-old woman presents to the outpatient clinic with a 3 months history of painless ulcer on the sole of her left foot. On examination, she is obese with a 1.5 centimeter deep ulcer over the first metatarsal head. Her foot is warm and pedal pulses are palpable. She has a hemoglobin of 13 grams per deciliter, normal urea and electrolyte level. What is most likely cause of his ulcer? It is a diabetic neuropathy.
Diabetic neuropathy, perfect. The site of diabetic neuropathy. Okay. Next question.
A 24-year-old man is assaulted and sustains a deep 2 centimeter long laceration to the lateral aspect of his lower leg. Physical examination.
Okay.
Physical examination shows that the physical examination shows that the laceration is anterior to the lateral malleolus. Which of the following structure is most at risk of being divided? Anterior to the lateral malleolus, peroneus brevis, peroneus longus, saphenous nerve, superficial peroneal nerve, sural nerve. It is the sural nerve.
This posterior.
Posterior
and this anterior.
Anterior.
Yesterday the question was
posterior. Yes.
Today, I said first it is. Today is anterior. So keep lateral malleolus, anterior to it is the superficial peroneal, posterior to it is the sural nerve. Sural nerve.
Anterior superficial, posterior sural.
Anterior superficial, posterior sural nerve.
Okay. And the next question. A 48-year-old woman presented to the emergency department with persistent diarrhea. On examination, she was apyrexial and had an regular pulse of 140 beats per minute. The most likely cause of the abnormal cardiac rhythm is hypernatremia, hypokalemia, hypovolemia, myocardial ischemia, sepsis. And she's in persistent diarrhea. I think it
The
will
metabolic
have
abnormality she'll have.
hypokalemia.
Okay. Sorry. Hypokalemia. Perfect. Okay, next question. Patient in vomiting or severe diarrhea will lose potassium, so we'll go for hypokalemia. In vomiting, he will lose chloride as well. Okay, next question.
A 45-year-old woman is investigated after 2 episodes of renal colic. A plain abdominal X-ray revealed small opacities in both kidneys. No abnormalities are found on physical examination. Biochemical investigations show adjusted calcium 2.8, which is high, phosphate 0.7, which is normal, alkaline phosphatase 195, which is high, creatinine 72, normal, paras hormone 12.7, which is high. Which of the following is most likely cause? Primary hyperparathyroidism, primary hypoparathyroidism, pseudo hyperparathyroidism, secondary hyperparathyroidism, tertiary hyperparathyroidism. Patient has elevated paras hormone, alkaline phosphatase is high, calcium also is high. So it is primary hyperparathyroidism.
High calcium, high parathyroid, or alkaline phosphatase. Primary
hyperparathyroidism.
But alkaline phosphatase is high here.
Alkaline phosphatase is raised.
100. We
100.
don't doubt tertiary.
Tertiary hyperparathyroidism.
When tertiary can happen? Renal failure or renal transplantation.
Yes.
What do you expect? Create will be high.
Create will be high, and he will tell.
So this is not tertiary.
Not
We'll tell you in the scenario exactly. But he told you in the scenario. This is part of the scenario.
Okay.
Okay.
It's normal chemistry. Okay.
Okay. Yeah. Next question. No one is ready to replace Dr. Mu'tasim. No one is ready. Anyone wants to share? Anyone want to participate? Dr. Ahmed Aziz has excused and go, and Dr. Dafir left. Dr. Ahmed,
sorry,
you have good.
Yes, I have something problem with my internet, so I don't know.
Okay. Dr. Sayed, ready? Okay, continue, Dr. Mu'tasim.
Okay, a 35-year-old man develops septicemia following a surgery for perforated acute appendicitis. He is hypotensive. Arterial blood gas analysis reveals pH 7.25, oxygen tension 7.2 kilopascal, CO2 tension 7.5 kilopascal, bicarbonate 17 millimole per liter. Which of the following is most likely explanation for this finding? The patient has respiratory acidosis, which is not compensated.
Or not compensated? Not compensated. Okay, so you're.
And also, the patient is hypoxic.
What about the bicarb?
bicarb is low. Also, bicarb also
It
is
means
low.
it is
It makes
acidotic or
metabolic.
mixed.
Mixed
Metabolic.
respiratory and mixed. Oh, yes, it is mixed respiratory and metabolic.
Okay.
If you low bicarb and high CO2.
Exactly. High CO2 and low bicarb. So this is mixed metabolic respiratory acidosis. Next question.
A 75-year-old man is assessed for surgery. He has smoked 25 cigarettes a day for the past 45 years. He is short of breath on minimal exertion. Chest auscultations reveal a widespread wheeze. Chest X-ray shows a hyperinflated lung. An arterial blood gas sample is likely to reveal which of the following changes. CO2, elevated CO2, elevated bicarb, high CO2, low bicarb, low CO2, high bicarb, low CO2, low bicarb, normal CO2, normal bicarb.
What do you expect this patient to have?
75, smoke 25 cigarettes a day. Is short in breath on minimal exertion. Patient to be COPD.
What do you expect the COPD to have?
Emphysema and to have
COPD. What is
COPD
the arterial blood gas of COPD patient?
Respiratory acidosis.
Respiratory acidosis, compensated or not compensated?
To be compensated because it's a longer term, it's a chronic disease. So expected to have.
So you will have to expect. So respiratory acidosis, what do you expect?
High CO2 and high bicarb.
So you will choose with?
Actually, I will choose A.
Exactly. Take care يا شباب في patient with COPD and patient to differentiate between sometimes give you not this scenario, sometimes give you to choose what the patient have. Okay, so can give you choose the patient has, this patient is taking muscle morphine intraoperative and this post-operative he is taking morphine and then give you high CO2 and high bicarb and tell you what this happened for this patient. Acute respiratory failure or acute effect of morphine, or the patient has COPD, or the patient has acute on top of chronic respiratory failure. In acute conditions, never ever you will find high bicarb. Kidney compensation start after 48 hours. So if the patient has acute problem in the first 2 days, mostly you will find the bicarb still normal. If the patient has both of them, so the patient has a chronic problem, so you have to go COPD or acute on top of chronic respiratory failure. Okay?
Okay.
Differentiate between acute conditions and chronic conditions in respiration. Normally, CO2 in metabolic conditions can start within few minutes. And the patient has a high bicarb, you can find a low bicarb, you can find the patient had low CO2 to compensate within minutes. But if the patient has a high CO2 to compensate by the bicarb, it needs about 48 hours.
I think
so
is
metabolic
question.
There's a question in MRCS.
Yes.
In MRCS about this. I prepared it in the acid base and ABG lecture I did a few months ago. Okay, next question.
An 18-year-old woman present with recurrent tonsillitis and spontaneous skin bruising. On examination, there is no lymphadenopathy or splenomegaly. What is the most likely diagnosis? Acute myeloid leukemia, agranulocytosis, aplastic anemia, Hodgkin disease, human immune deficiency virus infection. Recurrent tonsillitis, spontaneous skin bruising. It means the patient has problem in platelets and white blood cells.
Yes.
So it can be a plastic anemia.
Aplastic. So the patient has problem in the platelets and he has a problem in the white blood cells. Okay. So the patient have two parameters. So it will be no lymphadenopathy. So it is not a chronic acute myeloid, not Hodgkin. It is not HIV. So the patient will have aplastic anemia. Next question.
A 62-year-old woman presents with a firm irregular mass in the upper outer quadrant of the right breast. This is shown to be malignant on mammography and fine needle aspiration cytology. She is treated with wide local excision and axillary clearance. Which of the following histopathological findings would imply a better prognosis? Absence of HER2 amplification, Bloom and Richardson grade 3, more than 3 positive axillary nodes, presence of lymphovascular invasion, presence of estrogen receptors. I think answer is E. Presence of estrogen receptors will have a better prognosis.
Which is the best prognosis for cancer breast? Best prognosis?
Yes, in fact, I read the table. Favorable factors for metastasis.
The most important and favorable factors is
estrogen positive tumor.
The best is estrogen, progesterone, and HER2 negative tumor. This is the best prognosis for breast cancer to the patient to have estrogen or progesterone positive, and at the same time has HER2 negative tumor. This is the best prognostic factors for it. Okay, next question. We have 17 questions. Yalla, to finish within 20 minutes. Okay.
A 58-year-old man is due to have surgery for debutering contracture to release the ring finger of the right hand. Which one of the following regarding the anatomy of the ring finger is correct? Has a cutaneous innervation from the radial nerve. Has no. This is wrong. Has no cutaneous innervation from the median nerve. Has no cutaneous innervation from ulnar nerve. Has the flexor digitorum profundus inserting into the middle phalanx, flexor digitorum profundus. It is abducted by palmar interosseous muscle. Which is correct. Has a cutaneous innervation from the radial nerve.
Okay, why you said it's wrong?
So I'm sorry.
Okay.
It has a cutaneous innervation.
Ring has from all of them. Have from the ulnar, have from the median, has from the radial nerve. Okay. يعني شوف هنا هي هل لك no is here no
all
this
answers
both
are wrong.
Okay. Yeah, next question.
A 75-year-old man presents with deep venous thrombosis. Computerized tomography confirms the presence of thrombus in his left common iliac vein extending into the inferior vena cava. The common iliac veins join to form the inferior vena cava at which vertebral level? At level of L5.
L5. Straightforward question. Next question.
A 35-year-old motorcyclist is involved in a road traffic accident and fractures his temporal bone, completely transecting the facial nerve just distal to the geniculate ganglion. Which function of this nerve remains? Lacrimation, salivation from submandibular gland, sensation to anterior tongue, smile, taste. Just distal to the geniculate ganglion. I think lacrimation will be preserved.
Because of?
Because preganglionic fibers to pterygopalatine arises from the geniculate ganglion.
Here will be the geniculate ganglion. Okay.
Okay.
Here is the geniculate ganglion. All the chorda tendini and all the function and the rest of the fish here will go through it. The only which arise in the preganglionic is the greater petrosal, through which the parasympathetic fibers of the trigopalatine ganglia to the lacrimal gland is preserved. Okay?
Okay.
So the greater petrosal will be preserved. Next question.
A 30-year-old motorcyclist is brought to the emergency department after a road traffic accident. He has an open fracture of his right femur. On arrival, he is tachypnic and confused with cold and clammy skin. Which of the following physiological changes is most likely to be seen? Decreased reabsorption of water from the collecting tubules, decreased serum bicarbonate level, increased pH of blood, increased the secretion of sodium in the urine, increased the senses of collagen in liver. Patient is hypotensive and shocked, so it will be decreased bicarb level. Metabolic acidosis.
Metabolic acidosis, you will have decreased serum bicarb. Next question. Very confusing question. Okay, go.
A 50-year-old man on the waiting list for a hip replacement attends the pre-operative clinic. He has a body mass index of 41 and a risk of perioperative hypoxia. Reduction of which of the following volumes or capacities is this risk most likely to be due to? Expiratory reserve volume, functional residual capacity, inspiratory reserve volume, total lung volume, vital capacity. Patient is obese, body mass index of 41, so he will face problem in expanding his lung. So he has.
Okay, this question in BMI patient in obese preoperative for a body mass index. This obese patient 41. This is hyper obesity. This is obese patient. Okay, in this patient, reduction of the following volume is capacity is risk. Is the most risk is the functional residual capacity. Function. You can read this, please.
Okay. Obesity and anesthetic implications. Induction of general anesthesia causes a significant decrease in functional residual capacity, which is inversely related to the increased body mass index. A low functional residual capacity paired with increased intrapulmonary shunt, decreased chest wall and lung compliance, increased airway resistance, and atelectasis predispose the obese patient to rapid desaturation on induction.
Stop. خلاص enough. So, what is the most important parameter here? Functional residual capacity. Function residual capacity is the most important for anesthetist for patient to adjust patient pre-operative.
Okay.
A special obese patient. Next question.
A 4-year-old boy presents to the emergency department with a 2-day history of headache, vomiting, and drowsiness. A CT scan reveals dilatation of both his lateral ventricles and his third cerebral ventricle. His fourth ventricle was of normal size. It is suspected that he has an obstruction to his cerebrospinal fluid flow. At which of the following sites is obstruction? It is aqueduct of Sylvius. I think it is a repeated question.
Yeah, repeated question, aqueduct of Sylvius. Next question.
A 74-year-old man who has undergone emergency major abdominal surgery 2 days previously is noted to be confused. He has been on furosemide for mild heart failure. The plasma sodium is 122 millimole per liter. Inspection of the fluid chart shows that he has been written up for 4-hourly intravenous 5% glucose infusion. What is most likely cause for hyponatremia?
What is the mistake of this patient?
Patient post-operative no saline. Patient only.
Yes. What is the percentage
glucose.
we give saline to glucose in post-operative patient?
We give a liter.
Hello.
1 liter saline.
1 liter saline and 1.5 liter
glucose 5%.
dextrose 5%. Sometimes 1.5 to 2 liters. So this patient didn't take any saline. So the patient, you are giving the patient only water. You are giving water only to the patient. So what do you expect this patient to have?
To have hyponatremia. Patient
Hyponatremia. Already the patient has hyponatremia.
Osmotic syndrome of inappropriate and decrease of flow. Excessive intravenous fluid administration.
Yes, you give the patient excessive water
Dilution.
free saline, water free, saline free or sodium free IV fluids. So the patient got an hyponatremia. Okay, that's why we give sodium for the patient. Okay, next question.
During arch aortography, the vertebral artery would be seen to arise directly from which of the following? Arch of aorta, brachiocephalic, common carotid, internal subclavian artery. It is a subclavian artery.
Straightforward question. Vertebral artery go direct from the subclavian artery. Next question.
A 60-year-old non-smoker presents with a 3-month history of loss of weight, malaise, and breathlessness. On examination, he has left supraclavicular lymph node enlargement. Chest radiograph reveals multiple bilateral opacities. What will biopsy of left supraclavicular lymph node most probably show? Chronic inflammatory cells, granuloma, Langerhans type giant cells, multiple abnormal mitotic figures, Reed-Sternberg cells. It is multiple abnormal mitotic figures. Most probably it is
because this is left supraclav, so this is malignant. If the patient, he didn't mention this and mention the patient has multiple lymph nodes in the neck,
it will be
so this patient may be no.
Sorry.
In the neck, it will be mostly Langerhans cells, and the patient was coughing, loss of heat, and the maybe cavitation in chest X-ray. But Reed-Sternberg, where we can find it?
It will be generalized lymphadenopathy.
Hodgkin lymphoma.
Hodgkin lymphoma. Yes, Hodgkin lymphoma.
Hodgkin lymphoma. Okay, next question. Very easy.
A 12-year-old child was admitted to the emergency department having inhaled a peanut. Where will the peanut most likely to have lodged? In the right, left lower loop bronchus, left upper loop bronchus, right lower loop bronchus, right middle loop bronchus, right upper loop bronchus. It's the right lower loop bronchus. Because the right bronchus is more straightforward.
More straight, right lower loop. Very common question in the exam. Very common question in the exam. Right lower loop bronchus, as you see here. Right lower loop bronchus. Basically, if you look here, this is more straight. Next question.
A 39-year-old multipara woman who smokes 10 cigarettes per day presents with 2 cm by 2 cm tender lump in her right breast. There is a brown discharge from the nipple. Mammography is unhelpful and ultrasound shows some dilated lactational ducts. What is the most likely pathological diagnosis? She is a smoker, a woman. She is most probably ductictasia, fibrocystic plasma cell, thyroid, fat necrosis, breast abscess. It is not breast abscess, and it is not fat necrosis, and it is not phyloid tumor.
mnemonic for the same mnemonic
plasma
for
cell
duct ectasia is duct
Cell
ectasia is
cell.
the same like duct plasma cell mastitis, the same like duct ectasia, the same. Young patient, female, smoker, brown discharge, go direct to search for smoker. Young patient, mostly naripara. So it will be dilated, lactiferous ducts, plasma cell mastitis. Okay, or duct ectasia. Next question.
Next question. 56-year-old man presents with headache and vomiting with deterioration over the last 2 weeks. On examination, he has papilledema. CT scan shows a space-occupying lesion in the right parietal lobe. He develops a sudden homonymous hemianopia. Which part of the visual system to be affected? Lens, optic chiasma, optic radiation, retina, second cranial nerve. Patient has papilledema and has homonymous hemianopia. So it is optic the optic chiasma. No, not optic chiasma. The optic radiation.
Optic radiation. This
Optic
is optic
radiation, yes.
radiation.
Optic radiation.
This is optic radiation. One come here and one come here. This is the eye. This is the eye. So in crossing fibers come to here and this fiber. So the patient has homonymous hemianopia, whatever right or left. So this is the chiasma here. The chiasma here. So
Chiasma
if it is here, it will be ipsilateral or unilateral blindness. But when you have only one side, so you have some fibers from here, some fibers here,
so
which will affect this one. So it is on the, you said right.
Okay.
This is because of optic radiation.
Optic radiation, yes.
Okay. Next question.
Atrial depolarization is shown by which ECG change? B wave.
B wave. Very important. Of atrial depolarization by P wave. Then R wave, QRS will represent the R wave.
Ventricular depolarization.
Okay, where is the atrial repolarization?
It is hidden because of
hidden within the
complex.
QRS complex.
Within the
hidden
QRS complex.
within the QRS complex. And then the T wave will represent
ventricular repolarization.
Ventricular repolarization. So atrial depolarization P, ventricular depolarization here. The atrial repolarization will be hidden here, then ventricular repolarization. Next question.
A 65-year-old man with non-ischemic heart disease and atrial fibrillation presents with a paralysis of his right lower limb. Which arterial territory is most likely to be involved? Left
right
anterior cerebral.
First?
The patient has a right lower limb, so we talk about the left side to be injured.
Okay, which
and it is because it is a lower limb, so it is the middle cerebral. Middle cerebral.
Middle cerebral.
It will be right.
What is the upper limb?
Upper limb, anterior cerebral. On the medial side of the brain. On the medial side of the hemisphere.
Lower limb. You remember we see the body is represented inverted on the brain. So this is the middle and this is the upper. So you can find the lower limb here, followed by the trunk, followed by the upper limb.
Yes, upper limb.
Anterior cerebral artery, contralateral leg, and behavior changes. Middle cerebral, face and arm, yani upper limb, plus visual, plus. Anterior cerebral will take the lower limb. Middle cerebral
Yes.
will take the upper limb.
Cerebral.
Okay, so
Yes,
this is
yes. It is the right anterior
is-
cerebral. Right anterior cerebral.
left anterior
Sorry,
cerebral.
left anterior. Okay. لاحظ كده بدي
Okay, right lower limb. Right lower limb. تمام.
Okay.
Okay, next question. يلا 3 question left or 2.
Okay.
3 question. يلا.
91 a 91-year-old man becomes a hypotensive 2 days after, I don't know what is this, THR. He is found to be in atrial
Total hip
fibrillation.
replacement.
Total hip replacement, okay. He is found to be in atrial fibrillation with a pulse of 140 beats per minute after treatment with digoxin. His atrial fibrillation is loose and he has pulse rate of 90 beats per minute. Which form of the venous wave form is absent? In atrial fibrillation, absent A wave. Absent A wave.
A wave. A wave will be absent.
A wave, okay.
AF will be absent A wave. Next question.
A 56-year-old man with chronic emphysema is on the high dependency unit 10 days after anterior resection. He has developed the acute shortness of breath and hypotension. Which of the following landmarks would be the most appropriate to use to obtain a femoral arterial blood gas sample?
Where?
Femoral artery, mid inguinal point.
Mid inguinal point.
Inguinal point.
Exactly.
Which is a midway between anterior superior iliac spine and symphysis pubis.
Okay, mid inguinal. Just I want to know mid inguinal point. Midpoint of inguinal ligament, which landmark?
Deep inguinal ring.
Deep inguinal ring. Okay, last question.
A 45-year-old woman with insulin-dependent diabetes attends to the emergency room with abdominal pain and confusion. She has been treated for 3 days with antibiotics for chest infection. The creatinine is 400 millimole per liter and her blood sugar is 42 millimole per liter. The most likely severe electrolyte abnormality is hypercalcemia, hyperkalemia, hypermagnesemia, hypocalcemia, hypomagnesemia. Patient insulin-dependent diabetes, abdominal pain and confusion, 3 days with antibiotic for chest infection. I think it is hypocalcemia,
What do you expect the metabolic disturbance will have in this patient?
Patient has high creatinine and blood sugar 42. It is low or high?
High.
High. So it may be diabetic ketoacidosis.
So the patient will have metabolic acidosis.
Yes, we'll have hyperkalemia.
Hyperkalemia. Also, I don't know why. Many I found that they answering this answer hypomagnesemia. Why hypomagnesemia? I found no explanation to it. I found no explanation to it.
No,
but this patient has high sugar, infection, and for a long time on antibiotics. So the patient is expected to have metabolic, at least metabolic acidosis. At least metabolic. In metabolic acidosis, the patient will suffer from hyperkalemia.
Hyperkalemia.
Okay.
Okay.
Thank you.
Thank you, Dr. Rami.
Thank you, Dr. Mu'tasim. You did a great job today. So wish you get a good benefit from studying and discussing Fawzia Sheet the last 3-4 days. And hope you revise it many times because very, very important exam. And thank you and wish you all the best. Let us stop recording.
Okay. Kindly, Dr.